Good afternoon, members and representatives of CEO Munoz, representatives of CHCC, along with CEO Munoz. It is now 1:12 p.m. and I call this budget hearing into order. Before we begin, I'd like to introduce members of this committee. We'll start off with my far left, your right. We have Representative Leila Staffler. She is the chairwoman for Education. To her right, we have Representative Christina Sablan. She is the chairwoman for Health and Welfare. To her right, we have Representative Ed Probst, the chair for Gaming. And over to my far right, your left, we have Representative Richard Lizama, the chairman for PUTC. To his left, we have Representative Denita Yanktamai, the chairwoman for Commerce and Tourism and Cannabis. And to her left, we have Representative Vicente Camacho, the chairman for Federal Foreign Affairs. With seven, and including myself, Donna Manglonia, the chair for Health and Ways and Means. And so with 7 members present, that constitutes a quorum to conduct today's budget hearing. Also assisting the committee are the staff from the Legislative Bureau. To my right, we have the Legislative Assistants Giovanni Taitano and Cameron Nicholas. And then down here we have our Fiscal Analyst, Mr. David Napon, our Legal Counsel, Joe Tyrone, and assisting us with IT and the Sergeant at Arms, Mr. Dennis Regis. Just give me 1 second here. All right, moving down the agenda, members, can I get a motion to adopt the agenda?
Motion to adopt.
Motion was made and seconded. All in favor, say aye.
Aye.
All opposed, say nay. Motion carries. This leads us to the next item on the agenda, opening statement of the chair. Good afternoon, members of the committee, CEO Munoz, and it looks like your team at CHCC. Welcome to today's budget hearing, where we will discuss some of the submission that was made by the governor, which has projected expenditures as well as estimated revenues that we will go over. And should the members have any questions in regards to these expenses or projected revenues, we'll go ahead and ask that after you give your opening statement. So with that, I will hand the floor over to you, CEO Munoz, to provide your opening statement. Thank you.
Good afternoon, Chair Manglonia and members of this committee. In March, the CHCC, with the Board of Trustees' approval, submitted the fiscal year 22 budget as it relates to the health of all Cinema residents. I am joined by Chief Financial Officer Cody Santos and Chief Operations Officer Shuboto Banerjee, and others, including our Vice Chair for the Board of Trustees, Mr. Ed Guerrero, and others in the CHCC leadership, to answer any questions or concerns you have with our request. About a year ago, we were fortunate to safely appear before this committee, requesting support for funding for us to retain the limited resources of hardworking, dedicated healthcare workers, to ensure we have the support, tools, human and other resources to help improve the health of our community, to continue to protect them from the pandemic and to save lives. We responded to increase of CARES funding for the CHCC, and we explained that there was no dedicated funding for treatment and hospital improvements, that the CHCC was handed over in a silver platter, despite how almost all of the CHCC's team's involvement and in working with the governor's COVID-19 task force, in preventing this terrible infection from spreading wildly within the CNMI. We cannot forget and we are forever grateful for all the heart and soul the CHCC staff and management put into their daily work and continue to do so without hesitation. Unfortunately, even with all of this, the funding appropriated for FY 2021 to the CHCC stunned us. If we can put a value to what we do, the pandemic would and should have been one major indicator of how important our work is and how important health is to the CNMI population. Nevertheless, there's much appreciation with federal agencies that eventually provided the support given to CHCC for contact tracing, testing, and vaccinations. We must emphasize that funding, however, is dedicated to allowable costs, and we still needed to rely on revenues produced by hospital services. Hospital services require hospital staff. Contact tracing, testing, and vaccinations require the same people that are providing hospital services. The juggling of personnel is a daily chore for all of us. The grants that are open for CHCC to apply our focus on workforce outreach and incorporating the overall health issues our population struggled with pre-pandemic, during, and post-pandemic. We have yet to see and notice a funding opportunity that focus on hospital and clinic services specifically. Braiding and blending of funding streams, therefore, is a key strategy of the CHCC leadership to leverage toward health overall in CNMI. The integration of public health and clinic services makes this strategy a possibility and a success. With this strategy, even during the pandemic, we opened the oncology center that helped our people stay home and be with their families even when receiving cancer treatments. We just completed a CMS survey, and while there were findings, we had no flags for immediate jeopardy. And we continue to show that compliance with the Centers for Medicare and Medicaid Services standards is still our top priority. We have medical and nursing staff that are committed to doing more for this community they came to love. We continuously seek to bring much needed specialty care to our people. We can do more. We want to do more. Let us do more together. We can do more by addressing the gaps from care and investments we've already made for improvements. With the American Rescue Plan Act of 2021, we requested for funding to address some of these identified gaps in funding for more accessible care for our people. On top of hospital improvements and enhanced services, we also simply asked for the balance owed to CHCC from public laws and appropriations totaling $12.8 million. The overall ask from ARPA was $114.2 million, and our ask for FY22 is $24.7 million. And thank you for the opportunity again, and if there's any questions, our team is here to respond. Thank you.
Thank you, CEO Munya. And thank you for your presentation this afternoon. And just to recap, to go over our analysis of your budget submission. The expected expenditures for 2021 totals $104,086,973. Does that sound correct? And with the expected revenue coming from Medicare, Medicaid, and no others, we're looking at $72.3 million. Non-insurance revenues at $5.3 million. CHCC satellite source 1.7. So the total revenue estimate comes out to $79.4 million, which computes a shortfall of about $24.7 million. That's what you've just mentioned, correct? And of the $24.7 million that CHCC will need, the governor has proposed $86,000 from the general fund and 4.1 under the ARPA. So that's 4.2 total, which now brings you to a shortfall of 20.5 million. Can you just go over the statement you made? You requested 114.2 million, and what's that 24.7 that you mentioned?
The 24.7 is from the budget, as you mentioned. And the 114 million we did submit to the governor, requesting for, I'll get the list. Sorry. So we did ask for the balance owed from public laws and appropriations of $12.4 million. These were from public laws. Again, one of the things that we are always hesitant when we hear about public laws appropriating CHCC money, we often tend to not see that. So this is just one experience of several experiences that we've had. We've also we asked because we heard that there was a FY19 budget was a consideration for annual funding. So we did request, because FY19 actually was a good year for all of us. If you really think about what funding that was given to CHCC, was about $10.2 million each year. We've never gotten anything higher than that. And that was so we asked for that funding, which we thought was reasonable for us to operate. We also included Medicaid matching funds, and I can give you a copy of this. Medicaid matching funds for hospital expenses. The Medicaid payment for CHCC is using the Certified Public Expenditure methodology, which means that what we pay for our services is used as matching for the local share. We did that with, and it allowed us to use that and not get additional funding from the CNMI government for it. But the methodology did not say that it was to be waived. There's nothing in the state plan that said that CNMI government was not going to pay the matching. So we are asking for that matching, which I believe we have also showed that in previous years it was never done. So in 2021, we were expecting at least a higher FMAP because of the CARES funding that gave a higher rate of federal Medicaid assistance percentage. I think it was 40. So 89.2 is the federal share, and so obviously the difference will be 10.some% for the local share. So we're asking for 3.9 million for 2021, and then we asked for in 2022. Obviously, the President Biden's budget does include the cap removal and the aligning of FMAP share to be similar to the states, which will likely increase the FMAP share for the CNMI as well and other territories. But that is not, of course, certain. And so we did include it for FY22 a higher percentage of FMAP because the CARES Act funding actually for the increase of FMAP expires in September 30. So we asked for $13.9 million for match for that. We also requested for about $2 million, actually $2 million for the invoices for services that are hospital services. As mentioned in my testimony, is that our hospital staff have been really in the front line from testing basically everything all over the place, and some of them could be incorporated into the Medicare cost report for reimbursement. That's where we can get some funding for that. But hospital is hospital, so this is obviously not hospital, so you can't put that in there. Then you have, in addition, you have FEMA funding that pays for some testing and vaccinations. Unfortunately, surveillance, and this is what we've been told by the Public Assistance Office, that when you test individuals to get out of quarantine, that is not covered at an allowable cost under FEMA. So even though we allow that to obviously for mental health reasons too. We want to be able to make sure if we can test people out, we want them out of the quarantine site. That is not something that we were not reimbursed for. So we were paying overtime for our staff. We were paying actually we're not even paying hazard pay. We want to pay hazard pay, but we can't because we don't have the money at this point. But that's one of the things that we asked for. That is not CHCC's mission anyway. It should be a mission of the CNMI government. So we invoiced the government $2 million for the services, and this is to cover to the entire calendar year 2021. And we also asked for premium pay for our staff. As I mentioned, we don't pay for hazard pay. We only pay for the overtime, of course, because that's part by us anyway. But the hazard pay that we would love to pay for our staff is something that we asked for. And we not only heard, but we know that the ARPA funding specifically says that you can pay for it. So we simply asked, again, we feel like we are the frontline people also, so we needed to be included. If the CNMI government is going to pay premium benefit, why not us, right? So that's what we included as well. And last but not least, we asked for $58 million for hospital improvements and enhanced services. And this is to purchase an MRI, other medical equipment needed for critical services, and cost estimate for a new facility, for upgraded new facility across the street for a new hospital. New clinic services as well, and to renovate and modernize the old facility. So we want to expand, add more beds and add more services to the current facility. So it's about 40 million plus 60 million. So we went up to 58 plus 1 and so forth with the MRI equipment. So 58.3 million total. So that this included, so for 2021, a total of 89.9 million for 2021, and for FY 2022, we asked for 24.2 for a total 114.2.
Thank you for that explanation. Before we move forward, I'd like to recognize a member of the Ways and Means, Representative Patrick St. Nicholas, representing the island of Tinian. So for the current fiscal year and the requests that you submitted, have you heard back from the administration?
We did. We had a meeting with the Secretary of Finance and explaining, and we justified why we need these items, and there was just a discussion of that. We understood that probably there will be some funding that will be given to us this week for about $2 million of that request. For now, I hope.
Thank you. And as we see some of these ARPA funds being allotted to these agencies, and again, like you mentioned, knowing that premium pay was included in how these funds should be spent, has CHCC already started monitoring these, payroll so that when the funds get transferred, they'll be paid these premium pay, or are you waiting to hear back from the administration as well on premium pay?
Since the COVID activity have started, we have been monitoring hours dedicated to outside of the hospital services that we are providing to support the CNMI mission to protect the island. So the CNMI. So we are tracking. We have in fact calculated based on the parameters set by the ARPA law, and we have provided the information to the governor, lieutenant governor, and secretary of finance on how we calculated it based on current policies of safety and the limitations set by the ARPA.
Okay, but to date, no premium pay has been given.
Yes.
Correct. Thank you. Right now, I will open the floor to the members. I recognize Representative Salon.
Thank
Mr. Chairman, and good afternoon, CEO Munya, Mr. Banerjee, and I'm sorry I didn't get your last name. Santos. Thank you for your presentation, CEO. I was also stunned by the governor's submission for CHCC, and I guess I just wanted to ask, you know, you mentioned you had this meeting and that there could be $2 million being transferred. We are expecting the governor to submit a revised budget submission. But did you get any other commitments as to whether CHCC, who has been holding down the fort throughout this pandemic, will be getting any more from the American Rescue Plan or from the general fund for that matter under the next revised submission?
I don't, maybe I'll turn to, because we actually all met together, and we ended the meeting with just a review, and they will get back to us. I think that was that. I think I just wanted to make sure, and that was that we all had the same understanding that it was they would get back to us.
Okay. And when was this meeting?
About a couple of weeks ago.
Okay. And you went over just your proposed submission for just the ARPA funds, or also the 12-some million that CHC is owed for previous appropriations and all the other items that you mentioned? It was all the items?
We included the ARPA funds. You know, we've been asking for this for quite a long, so we've been using all kinds of methods to try to ask for it. So this was, we figured, put it in there because obviously there's money.
Right. Okay. And then I guess my next question is, you know, Vice Chair Leila Staffler and I signed off on a support letter for a package of proposals that you had submitted to Congress for funding consideration. My understanding is that that's for the next infrastructure bill that's being drafted.
No, that was for the Congressman Blunt's package.
Right.
Right, for the earmarked funds, federal earmarked funds. So we have not heard back whether or not. Yeah, we have not. No.
Okay. Okay. But are those but the infrastructure, the hospital improvements and services that you requested from the governor, the 58 million for ARPA, are those the same project? They're different.
They're different. The amount for the earmark amount for each project is less than 5 million. My understanding, so less than 5 million. So this obviously will not fall into that. So we did not include it.
Okay. Thank you. And then just shifting gears a little bit on the question of medical referral and what to do with medical referral. I do recognize that the budget proposal does not assume the transfer of the off-island program, but I wanted to ask if you had thought also about the option of transferring the inter-island referral program out of CHCC.
Oh, yes.
Is that something that has been considered?
She's smiling. Yeah, I mean, if you go back to Public Law 1651, it was not separated, and then 1970 separated. It is a burden on us to run it as well as part of that. I mean, especially since we're using the same people that are processing everything else. So it's, you know, their footprint is all over the place, but this is something that we've made a commitment to, of course, have to provide. So there's no revenue generating whatsoever, but still we have to do this and provide these services. Yeah, so getting it out to a program where, for me, I think it needs to be together. I mean, it shouldn't be fragmented the way it is now. I mean, I hear so many stories of, you know, how someone from Tinian, for example, would have to go to Simon and then go back to Tinian and then wait for the referral, the other agency to process that. So that to me is just doesn't make sense.
Right. Yeah. Okay. And you mentioned that relying on appropriations to cover all kinds of hospital services, but you don't actually get the money a lot of the time. And I assume that that's the case with the Inter-Island Medical Referral Program.
Correct. It's when there's funding, it's usually for stipend.
Okay.
Okay. Yeah.
Okay. Do you have a balance of how much is still pending transfer to CHCC for the Inter-Island Medical Referral Program?
there's nothing dedicated for a medical referral program for us.
Okay.
And the internal medical referral, there's nothing dedicated. But the stipend, whenever the local delegations come up with laws to pay for stipend, that's when some funding comes to us.
And otherwise, you just rely on your regular operational budget? Okay.
Yes.
Thank you. I yield for now, Mr. Chairman.
Going back to Sablon's line of questioning in regards to inter-island medical referral, do you have the how much of that is costing CHCC on a monthly basis or annual, if that's what you have?
Yeah, about 700,000 annually. And for the past years, like 17, 18, there were 100,000 appropriated for housing and airfare. But like we said, there's no stoplight to illness. Even though that 100,000 is exhausted, we continue to provide the service, the airfare and the accommodation for the inter-island medical referral.
And your vendors to these hotels and airlines are up to date
Yes, sir.
with payment?
Yes.
Thank you. Floor is now open. I recognize Rep. Staffler.
Thank you, Chairman, and thank you, CHCC teams, for coming. I don't have any major questions. I'm just curious, maybe you can explain. There were several increases in the budget and just the larger increases. Maybe you can describe the project's plan or how it's going to be used. There's a few that I was curious about, and so I'll just start. There's 43% increase in dues and subscriptions. What kind of dues and subscriptions have increased? You know, what kinds of things are going on with that? A 99% increase of license fees and such. 101% for rental housing. 12,063% on improvements, which are exciting to hear about possibly, and 102% increase on office equipment. So what are your plans?
You want to identify them and then I can justify.
Thank you.
For the licenses and then subscription, we are in the process of a huge health information system upgrade. So we're hoping to modernize the way we record healthcare information so that we would be able to spit out more timely bills, because that's our objective, is not only to timely bill, but to properly capture health information, right? So that's the licenses and dues. And the improvement, if you're comparing it to actual, or are you comparing it to budget, ma'am?
Sorry, I didn't have this document. I was looking at I guess it's the budget, just budgeted, yeah.
So budgeted to budgeted, yeah. So over the years, especially with COVID, we realized the improvements in the hospital have been left behind, because we are focused. We've been asking 19 million, 20 million, millions in appropriation so that we could do this, but we don't get. So we stopped putting it in the budget, right? So we realized with money coming, it's better to ask. We ask our projects, our programs, our Tinian and Rosa to put in your request, your wish list. Let's try to put it in so that we could hopefully get these things done.
So the 12,000% increase is just all the different improvements that you've been wanting to do over the many years that you've never received. Okay, thank you. Anything else you'd like to share?
Yeah, yes, there's, like she mentioned, properly mentioned, that there's a lot of things that we basically asked the team to really come up with some, say, what did you want to do? What did you want to improve? And there's a lot of things, and a lot of times we've been holding back because of the cash flow. But so we figured that this was the right time to ask and put it all together. Yeah, so we basically said, do what you wish to do.
Excellent. I think investing in our facilities and improvements is something that we often fail to do because the pressing needs of today sometimes trump that. And so when there is time, it's good to ask. I think you are on the right track. You had 4.8 for CIP projects. I'm guessing that's different from this 12,000% increase too. So that's additional projects, correct?
The improvements would be like repairs and maintenance, right? And then the CIP would then be the capitalized, the full, yeah.
Oh, wow. So moving on from those things, thank you for sharing all those great updates. There was a note in our summary that shared that there was not a audits available for 2018 and 2019. Is that something that is going to be available, or what's happening with that?
Our audit has been delayed. We've been working with our former auditor, Deloitte & Touche, to close out the 2018 audits. We just contracted with the new auditors, Ernst & Young, to concurrently work with the 19 and 20. Hopefully to get it done by September 30, 2021. So that will be timely on our 2021 financial audit.
Thank you. Ayub.
Thank you, Rep. Stapler. Before I move on to the next, or my apologies, I'll go ahead and allow folks to ask his question.
You sure, Chairman?
Yeah, go ahead.
All right, thank you. With everything you guys have been doing and keeping our community safe, I know that sometimes there are tough decisions. You guys get a lot of flack for being so strict and everything. I want to commend you for being strict. You know, you got to be tough parents, tough love to really ensure our safety. So I commend you all, and I'm sad that people don't get it. But nonetheless, you know, our healthcare is one of the most, if not the most important thing for all of us. And I'm always sad to see it short-sighted when it comes to funding. And then of course, every year since I've been a legislator, we come and you come hat in hand asking for, you know, as much as you can. And you know, you're basically often shortchanged and you have to figure out other ways to keep a hospital running. I tend to remind our constituents who also have complaints about CHC that CHC, because they cannot refuse service, is not in the business to make money. It's not, you know, I mean, they're not a private clinic, let's face it. So I do admire the ability to do all this with all the challenges ahead of you. I just wanted to ask with regards, I have a few questions, but the first one is on the actual infrastructure of the hospital. We've heard concerns about the building itself and everything. I would like to ask if, from your thoughts, do you feel that the infrastructure, the hospital itself is still in great condition? Do you think there is a need for a new hospital? What are your thoughts on that?
We thought a lot about it, and even with the CMS survey, even with the consultant that came over and worked with us, it's costing us a lot of money for maintenance. There's just a lot of things. I mean, from the RO system, just things that needed to meet even standards. We were so glad that the Life Safety Code survey came out with 0 conditions. So that was good with CMS. But we spent a lot of money to try to make sure things are there to provide treatment. I mean, even to the point, just temperature control is an issue because of humidity and the heat and on climate. It just to the point where we have to do something and make changes again with the building itself. A lot of leaks, that we get a lot of leaks, and those are things that come up, and so it is costly. So if we want to stop, at least minimize the cost, obviously yes, and a new building would be great. We came to the point where, and facility director Warren is here, but to the point where we look at the rooms and say, we would like to see an upgraded room. how much is that gonna cost? So let's do it one room at a time, so that's how we came up to see how we can fix it. We talk about grading and blending. We look at how some of the federal funds can be applicable to some of the healthcare services that we already provide, and see how that can be allowable. We talk about clean audits, right? So we want to make sure that we, a former controller, a former auditor, she's right here, so she knows what's not to do and what to do. But, she's been a great advisor for that and moving forward. But there is a lot of things that we need to fix in the facility. We did get our CARES money from DOI that looked at, for example, upgrading the ER. So that is, but it had a time limit of when to use the fund. So that was really was a juggle for us. It's to even provide privacy in those rooms. I don't know if you've been to the ER, but there's some problems there, right? In order for one person to use a restroom, they have to go to another person's room. So the design of that was in 1986. Mind everyone, it is time to upgrade. It is time to make changes. We looked at building another hospital clinic services across the street, right? There's that land there, to minimize the cost. Obviously, a hospital will probably cost about, even in Guam, they're talking about maybe 300 million, right? Probably over 100 million, for us here, and to add more beds, and to make the beds, make it much easier to support the staffing that we have. There are times when staffing cannot be there. If you've been to the hospital, I'm pretty sure. So you see the state nursing station, and then you have these rooms far away. Monitoring is very, very critical, and just adding more beds would be, making it modernized, to be able to say, hey, work with your workforce and make it workforce friendly. I guess that's what I wanted to say. So yeah, it needs changing. So it costs money for a lot of maintenance. I think that people even ask for specific rooms now because they like one of the rooms that we've upgraded over the ones that we're not. We would like to make it available for everyone. So yes, I agree.
And I thank you for informing us of this, because if you recall back in the day when, because tourism, of course, is always our huge concern, and there was a time when we were trying to chase the golden age where we get elder people to come in and live, and the challenge that we had was medical needs that they may have, and that ours just wasn't up to par. And I look at this as an opportunity with all this federal funding coming in, that we should be investing, as several of my colleagues have mentioned, as Chairwoman and Rep. Selena Babat and others have been championing either a new hospital or really putting money into and investing in state-of-the-art healthcare, the best that we can offer. Because certainly there's a correlation that if we do have really strong, high-quality healthcare here, it also can correlate with confidence when it comes to tourists, but also those that may want to stay here for many years and buy a condo or something. So it's just something that I feel very strongly that we should make a decision on that and support it. On another note, I wanted to ask, because you are, you can't turn people away for emergency healthcare or anything. How are your collections? When somebody can't pay, I think we've talked about this before, but you can put them on a sliding scale and all this, but is your collections right now, is it in-house?
Yes, sir.
Okay. I was just wondering, have you ever considered, say after a certain period, if you're not collecting, have you considered sending it to a collections agency, or do you guys send it to a collections agency after say after a year or 2 years of failing to collect, or something to that effect? What happens at that point?
Yeah. If you look at our receivable, a significant portion of it are third-party insurance, right? And then the small minority, which constitute the compensated care, right, are sliding fee patients. So we did try before doing a collection agency, but it's just like a fixed fee that doesn't really turn money back,
Okay.
right? It's just another cost to us.
So it was, okay, that's what I was curious to know. Somebody had brought that up, and I wanted to be able to come back with that information, because they felt that if we did send everything to a collections agency, that everything would be great. And I don't know how that really works. And especially when we're dealing with indigent care, we're supposed to be a compassionate people. I don't want to, so it's a very difficult subject, and that's why we should be receiving costs for uncompensated care and other things. So, sorry. And last but not least, I wanted to talk, we were in Rhoda recently for budget hearings. One of the things that the mayor had mentioned was that he wanted to bring all the dialysis patients back to Rhoda, and we wanted to, we're curious with regard to the cost. Is that feasible, first of all? And if they did, I guess, invest in a clinic there for dialysis patients, is it self-sustaining? Meaning, if we do have this federal funding that we're utilizing now, after it dries up or whatever, will we be able to cover the costs for dialysis patients in order to continue that type of service? I know that they want to move them back, but at the same time, we are talking about unlimited funds, and something that I was always concerned about, and I'm sure my colleagues were, is if we did put all that money into it and there was funding for the federal funds for the next couple of years, again, if we don't have that type of another ARPA or other funding for this, then can it be self-sustaining? So what are your thoughts on having dialysis patients return back to Rhoda? Thank you.
My thoughts on getting the dialysis patients back to Rhoda, or Kenyan for that matter, is yeah, I mean, it needs to be done. The challenge is all about money and sustainability, like you said. There's we have to be mindful that even our nephrologist is being utilized by the 2 dialysis facilities here. So even just hiring one nephrologist to come and serve, serve the people here is difficult. So there's, we're almost challenged to the point that, challenged by workforce. We have people moving from one facility to another. So that to try to sustain that would require a lot of money to attract the healthcare workers to come and work to do exactly that. So those are things that we've talked about, and with the board is concerned, and it's just money. And I've heard where someone comes up with suggests a solution would be outsource it, getting it to someone else, and that's fine and dandy, but you're outsourcing it to someone, but then the company that you're outsourcing it to will not make money and will require some subsidy from the central government. So if the central government is going to subsidize that, it begs to question, we have to question, well then why don't you give it to us so we can provide the service? But it seems to be like not an option that was offered to us. So just wanted to say that.
I thank you very much for your answers, and Chairman, I yield.
Thank you, Pro, and for bringing up your concern regarding the dialysis. It was something that Patrick and I,
Can I add something?
Sure.
Sorry, I forgot to mention that peritoneal dialysis is something that we are looking into, but it does require a lot of support. that is the, not only for, if there's no power, we need to make sure that there's that support whenever they're, whether it's in Tinian or Rota. So we have actually increased our peritoneal dialysis to about 12 patients here on Saipan. So something that can be done also for Rota and Tinian, that would be, it's just a lot of confidence for individuals to say, okay, I'm going to have my peritoneal, the dialysis at home. But again, for us, I think it requires that support so that whether the supplies are delivered directly to the facility where they can, that's one of the projects actually that we recommended for Congressman Sablan's community project, is to have a hub for both islands to have that support for the dialysis patients that want to stay in Rhode and Tinian.
Thank you, CEO Winnie. I now recognize Rep. Zama.
Thank you, Mr. Chairman. Welcome, CHCC. We mentioned about MRI. Do we have that presently in our hospital? No, so that can also help us decrease the spending on referrals. With that option, I believe that this body should push for your request. And that's majority of the funding, so referral funding segment being used. So yeah, I'm glad to hear that, and I hope that we do have one on island.
Yeah,
You never told me about that.
that's funny. We do have a radiologist on island already that's full time, but there are some, we've tried to ask for MRI funding through the community project again, one of the items, and we're heading it into the ARPA funding. Whoever wants to give it to us, please give it to us. There are some, specialty, especially in regards to cancer treatments. The oncologist is asking for this service. So it's something that we would like to have. If we can provide it, we need a lot of training. We need a lot of, obviously training and staffing is key as well. And a dedicated generator. So there's a lot of cost to it, obviously, as we were studying on how to get one.
I do.
Thank you, Rep. Zama. I recognize Rep. Camacho.
Thank you, Chair, and welcome. Thank you for being here. One question. Well, first, I'm gonna have to say thank you for all that you've done. This past year and a half has been quite bad. We're all going right through it, and I have to say that you really you've done very well. That's all I can honestly say. But I have a question. What kind of correlation or collaboration does CHC have with the VA clinic? Do you guys tend to the patients there? And is there any compensation for from VA for supporting them?
Yeah, we do have, refer to the VA, we do have our staff, our medical staff communicate with the VA clinic. So we do have that. Some services are provided at CHCC. If obviously services can't be provided, then they're referred. But the services are provided, we work with the VA office here to ensure that somehow we get paid for the services that we have, because sometimes it does require pre-authorization for that. So, but yes, we do have that relationship. Because we are Medicare, and that's the other thing too, when we talk about Medicare, meeting Medicare requirements, it allows us to bill for TRICARE, VA, basically anything that's federal. It allows us to do that with that, meeting that standard.
Thank you for that.
Thank you, Rep. Camacho. One thing I do want to point out, thank you, Ms. Burley, for your report that we received this morning. In regards to your accounts payable, 20.8 million is owed for CUC. Now, how far back does that go? And where are you now in regards to your agreement with CUC?
Yes, sir. The 20.8 million are only the principal amount. CUC when they report it would include about 20 million in penalties. So they would report about 40 million to you. So this is just the principal amount, and it dates back from incorporation to 2011. Last year, we, with the help of the governor, we signed a settlement agreement with CUC to be current with our current bills, to pay them monthly 69,000 out of our own revenue and 150,000 from the CNMI governor's office. So we've been paying CUC 219,000 monthly beginning October last year. So, but that's still not enough to pay all, to even dent on the past due. So it's just being current on the current bills, but the past due and principal is not paid.
Oh, wait, I'm sorry. So you're saying that CUC will report that they are charging 20 million in penalties,
Yes.
but that's not part of the settlement agreement?
We have not entered into a settlement agreement for the past due. So our agreement was to pay current monthly bills so that they will not disconnect.
Which is why I brought that up, because based on last fiscal year's budget requests, CHCC had requests 4.8 million, but for next fiscal year, the request is at 3.6. That's a difference of 1.2.
The 3.6 is based on actual usage. We've been trying to conserve as well, realizing some cost savings on other areas of the hospital, but obviously we can only cost save as much because we need to maintain air quality and all the temperature control CMS guidelines. So the 3.6 request is based on current consumptions and the reduced sewer rates, because in the past years our sewer rates have been overbilled, so there have been an adjustment on sewer rates based on some mathematical engineering calculations. So we were able to save about 100,000 a month on sewer charges.
Thank you. And you also mentioned in your email that you weren't able to pull the full summary, but in accounts payable, the ones that you did list is the 20.8 to CUC, 3.2 for unfunded pension obligation, and 4.1 to vendors. Do you have a total figure?
Yeah.
If not the list?
The 28 million in the accounts payable section of the financial statement is constitute of the 20.8 million CUC, 3.2 NMI retirement fund, and 4.1 payable to vendors. So, yeah, we have not paid CUC, and the unfunded pension obligation prior to the settlement fund is still in our books, 3.2. Yeah, so our regular vendor last year accounts payable is 4.1, primarily suppliers of medical and general supplies.
That's as of last year, you said?
This is as of March 31, 2021.
So clarified. Floor is now open to the members for the first round. I recognize Representative Patrick.
Just one question like with Chairman Prop's question about dialysis for the island of Rhoda and Dinalat, of course. How much do you usually charge a patient going through dialysis every other day.
200, almost 300 per treatment.
$300
Dollars.
does the insurance is included for the payment, or it's just?
Yeah, the insurance covers it. Medicare usually covers, it's one of their Medicare eligibility. If you are on end-stage renal disease, you are actually qualified for Medicare. Medicare Part A, and then you have to enroll in Part B, which we actually pay for the enrollment cost for that, the monthly cost.
So how many dialysis machines do you have right now?
We have 26.
26 machines, and you also
Those different shifts.
Yeah. So sometimes you just refer a patient over to a private clinic.
No, the patient has a choice of where to go. So he or she may be happy with our facility and finds a reason to go to the other facility, whether it's transportation or with scheduling or something. Maybe we don't have that schedule, so it could be something that they could go elsewhere. So there's 3 currently right now that are providing dialysis services, CHCC, Saipan Renal, and Sage.
I'm not really sure what's the number of patients from Finland. Do you know the number of patients doing dialysis from the island of Finland?
About 8 or 9.
And the machine, do you know how much does it cost to get it?
Wow. Paid about 10 million. About 10 million over time that we have to. It's almost like a lease to own. So we did have a contract with that back in 2011, 2012 maybe, something like that. And so the machine will probably likely need to be replaced also. So something that we are looking into as well. But so far they're working fine, but it's just a lot of maintenance that requires work on it.
CEO, the reason why I'm asking this question because the TN leadership are trying to cough up some funds to hire a professional to do some research about having a dialysis center down in the island of TN. We will maybe one of these days we'll call you in, and so thank you so much for your answer. I am Mr. Chair. Thank you.
Thank you, Rep. Patrick. Going back to the questions on payable and receivables, I have here with me I believe provided by Ms. Purdy also, the summary of receivables as of March 31st, 2021. I am showing a total of 16 million, but as we look through the years, yeah, I just want to hear from you guys what's going on with that.
Part of regular business of a hospital are contractual adjustments. So when we bill certain amount because of our contractual agreement with our third-party payer, some of the amount have to be disputed, so adjudicated, right? So while those bills remain as receivable on our records, they are subject to review for either adjustments or billing to the patients, right? So it's that's why you see there a record of 25 million cumulative account receivable with allowance for uncollectability of 9.8 million over the past 5 years. If I may add, our receivable balance constitutes about 1/6 of our bills. So if you look at Aetna owing to 2 million, they actually paid us Aetna 10 million last year, right? So this could be a contractual adjustment that have to be adjusted to patients or have to be lost for CHCC for meeting some parameters in the document. But note that the receivable balance is a small fraction of what is actually collected in revenue.
Thank you, so clarified. At this time, I would like to recognize our fiscal analyst.
Mr. Chairman, I just want to go back to the question that was asked by Congresswoman Staffler about the status of FY 2018 and FY 2019 audit report. And you mentioned, Ms. Santos, that you're planning to change the auditor from Deloitte to Ernst & Young. And so I think it's important that we understand the reason why there's a change of auditor. And if I can go further, Mr. Chairman, based on record, Deloitte has been the CNMI auditor for many, many years, and even with the CHCC. And the latest posted audited financial statements for CHCC in the OPA website is as of FY 2017, if I'm not mistaken. Now, if CHCC were to change auditors from Deloitte to Ernst & Young, would the issuance of FY 2018 and 19 be further delayed? I just want to clarify that. Thank you, Mr. Chairman.
We are in the process of finalizing the 2018 audit. We received the draft from Deloitte last month, so we're working on replying to findings and preparing the MD&A. So the audits for 2019 and 20 is now contracted with Ernst & Young. It is best practice for government agencies and private agencies to rotate auditors to get a fresh look at the financial statement and the financial condition of the corporation. As you mentioned, Deloitte has been the auditor of the CNMI government and of CHCC since inception. So we felt that we needed to, we bid it out. We did not bid it out with the intention of changing auditors, but in the bid process, we ended up awarding it to a different auditor, Ernst & Young. But it is really best practice for, as I'm an auditor myself, to let auditors be rotated so that a fresh view of your financial statement and fresh input on how to better improve internal controls.
Thank you, Dave, and thank you, Ms. Burley. I would like to now open the floor for a second round, and I recognize Representative Solon.
Thank you, Mr. Chairman. And just going back to the summary of receivables that you provided, I did notice I understand what you were saying, Ms. Santos, that this is a small fraction of the actual revenues that are collected, but there are some pretty significant sums still that that particularly with the local insurance companies. And 2019 seems to have been a year where the numbers were highest. And I was just wondering if you could just shed more light on that. What happened in 2019?
We always joke that as we improve on our billing, because we bill more, therefore the adjustment amount is bigger. Like we billed over, in this year, we've collected 60 million. So like I say, this receivable is a sixth of our total bills, right? So when we actually bill more, the adjudication process, we're a victim of our own success, right? We provide more services, we bill more. So it may look bigger in number, but in percentage to total bills, it's just the same. But you're looking at the the absolute value, right? You're looking at 2 million versus 800,000 last year.
Right.
But if you look at actual billed and actual services, it's the percentage proportion of the receivable balance at year end is equivalent. It's just that you're looking at the absolute value of the amount, right? So it looks big because we're growing.
Yeah. Okay.
Yeah.
And I'm just curious, like, how long does this adjudication process take? Like, you gave us figures going back to 2017.
Yes. So that's why there's allowance for those years. So the 2 years is a reasonable amount period for adjudication. So the prior years we do provide 100% allowance for uncollectability, but that doesn't stop our revenue director from negotiating with this third party insurance companies from settling what was disputed. So as we only keep 2 years in current receivable, you notice the allowance on the previous years.
Okay.
But we still try to collect.
Okay. And then my next question for CEO is if you could provide us with a summary of the findings from the CMS survey. You mentioned that there were some, no immediate jeopardies, thankfully, but yeah, could you just provide the highlights, and is that report publicly available this time?
There's the survey was completed about the 21st. So they have 15 days to report back on the actual document that can be available. But it would have to be requested through FOIA. So, but anyway, the highlights of it. So obviously the highlights were. There were highlights of, there was one in concern of care. There was one concern of care between two departments where a patient was transferred from one department to another department, and there was a miss of communication. So that was something that was found. And then there were mainly most of them are just standard of findings. So they could be, for example, let me try to think about the contracts, the contract review, monitoring of contracts. For example, when we outsource contracts, we should be doing better in following up on the compliance. So when we outsource it, that the vendor that's providing the service needs to be meeting the same compliance as if they were employed or provided by CHCC. So that's one example. I was just kidding about the FOIA. So until we get the report, which is about 15 days from the 21st, 15 working days, then we can discuss it and basically share it with the media as well on what it is. I mean, I think that one of the things that was mainly highlighted is that there was improvement. That's something that the surveyors found. Were shocked that there was no COVID patient. They were shocked that there was no COVID patient in the facility. So that's, we had to kind of explain ourselves. For example, they wanted us to hire 10 screeners. And we said, why? And they said, well, because what happens if there's COVID? We're like, there's no COVID here. So those are things that kind of come to us, and we have to explain why we do what we do, and so they move on to the next area for review. So, but they did a full survey. So that was something that we were sort of surprised. Because what happened was in 2019 they did a full survey as well, and then we came, they made some findings. It was focused on medical staff and nursing, and they were supposed to come back and resurvey if we've met the plans of corrections that we provided. So that did, because of the COVID, they were on a pause to do inspections. And so they came to the CNMI as soon as they lifted the pause, we were like the first in line to be inspected. So we were surprised that they did a full survey.
So
we're not
when you
expecting
said
that.
it was a full survey, that included like the alternate care site and?
No, the alternate care site is not ours unless it's warm, what we call warm.
Okay.
So it was the facility as it is now is not in our hands until a patient is it's considered warm if a patient is admitted there.
Okay, so strictly the CHCC facility at Navy Hill and then also the health centers on Road and Senior?
Road and Senior is not a Medicare facility, so only the hospital is one hospital and the clinics.
Okay.
And so a full survey meant all the conditions that we have to meet are always basically, they went all over the place, to life safety codes, environment, radiology, everything. So even though those findings, they were not findings in 2019, they went back to those areas even though they didn't find last time. So.
Okay. Okay. So that report should be available soon.
It should be available as soon as we get it. We actually, so the document doesn't get open to the public until we respond. So we also have 10 to 15 days to respond.
Okay. Okay, thank you. I yield, Mr. Chairman.
Thank you, Rep. Sablan. I recognize Rep. Camacho.
Thank you again. I'm looking at your summary of receivables, and I see three categories of Veterans Affairs on VA Admin Medical Center, Department of Veterans Affairs, and Veterans Evaluation Services. So these are apparently all the services you work with. But why? I can't believe it. Since 2017 up to date, there's 1,027,000 the VA Department of Veterans Affairs owe. I wouldn't think that they owe you anything. Can you just kind of explain that for me, please? Thank you.
I don't have the detailed bills related to this, but as I have explained earlier, this could be bills that are subject to adjudication. Services we provided maybe to veterans that did not meet prioritization. But I am just assuming the scenarios because I don't have the actual bills with me. But I will have to verify with our revenue director, Ms. Tiffany Sablan, if you would want to get more detailed information on these balances.
Thank you. I yield.
Thank you, Rep. Camacho. Any other member? For the third round? All right, thank you. I recognize Rep. Yanktamay.
Thank you, Chair. Welcome, CEO Munya and team. I just want to share what a viewer sent to me. And this was mentioned already about the ER situation needing upgrading, and maybe an entire building. And also better pillows and blankets because it gets so really cold in there. And isolation room that's completely isolated because they can still hear. I mean, I guess the curtains, I don't know what. And also a nurse, a professional nurse for the needles. I guess they need someone who can, inject properly, or I don't know how they, because some of them, they come out with a lot of bruises. So that's all. Thank you. Just want to make sure that I mention it so she can hear it. Thank you, Chair. I yield.
No, thank you. And I really do wish that everyone who has issues and concerns to bring it up to us. We do have a grievance form and an opportunity for anyone who has an issue. We don't want to wait for a survey by CMS to discover something that it was not shared or discussed with us. At the end of the day, all of us here, I mean, the chiefs and the board of trustees want to address the concerns of every single person that comes and, has our services. And we will, so there is a grievance form that's available. They can go to the cashier, they can go bring that up, because as complaints are received by my office and by our quality team, we look at that and, figure out how to address it quickly. We don't want you to leave without that being addressed. So please encourage your constituents to do that, to use the system that's in place. And of course, going to you is also fine. Thank you.
Thank you. For the third round, Representative Sutherland.
Just because not enough questions have been asked about COVID yet, but there were a couple of things I wanted to clarify. One is, and this came up during one of our town halls, is the cost of testing when people are leaving island and request either a PCR or the other test. So the question was, why do they have to pay if those are federally funded tests?
So the tests are free. You're right. The tests are federally funded, and some of them are actually paid for by us. So there's tests, for example, in some flights require the antigen testing in addition on top of the PCR testing. So we pay for those, and then we provide that, and that's for foreign countries, foreign country travel. First of all, we don't really urge people to get tested because it's not necessarily required. That's something that I think a lot of people are, and we did correct the messaging that did go out once, and to say that you don't need to get tested, don't get tested, right? But it does cost money for us to do it because it is our nurses in the clinics. There's no dedicated COVID nurse or COVID staff to do testing. It requires long hours of waiting preparing for the specimen to be tested, monitoring it. One of our lab staff, or two of our lab staff, was it already three? Three of our lab staff have left the island because they're stressed because of all the COVID tests that has to be done. So this is something that we pay ourselves, and it's not billable to insurance, so we can't get that funding anywhere else. And so we look at that, and it is in our fee, and it is allowable to charge. So we charge for it based on what's the going rate for testing. So if the going rate is $300, we charge for the $300 because there's no funding that's going to pay for it, and there's no insurance that we can bill for it. So yeah, so that's my.
And I guess the specific question that was raised by a constituent, just for your awareness, was, for our students who are leaving and going to Hawaii, where I guess the PCR test is required if they want to get out of the 14-day quarantine requirement. I know these protocols are always changing, but the question was, is there some kind of process to request a fee waiver in cases where the tests are required and where a student or somebody who doesn't have the means to pay the $300 or whatever?
If we have the resources, we would, but we just don't. So if we're paying our staff that's doing it and causing so much stress to it, and we're paying overtime to get it done, it is out of their regular duties that they have to do this. The only time we actually do waive, and we feel that it is because, again, that's our mission. Our mission is medical treatment, right? So when someone is going off island, even though they're not going on medical referral, we do offer a discount.
Okay.
And that's at least, if we could get just a piece of $50 versus $300, for example. And that's for those going on medical referral. No, sorry, those who are going on medical reasons, but not necessarily medical referral.
Got it.
Medical referral, we don't charge.
Okay, and then my last question, what is our vaccination rate now, CNMI-wide?
CNMI-wide,
Yeah, so with regard to vaccination, we're almost approaching 70% of eligible individuals who have completed their first dose. We have approximately 24,000 persons that represents first dose, and of those, almost 22,000 have completed their second dose. So our second dose completion rate is almost 98%.
Are you seeing like a slowdown at this point? Have we plateaued in vaccinations? I notice you're offering incentives. Are we going to be doing lottery tickets next? Like, what? How do we get more people to vaccinate?
Yes, yeah, it's a great question, and we're all experiencing that here in the mainland as well. We are doing as well as implementing incentives to be able to get folks in the first dose. We are looking at ways in offering different locations. So when we began, it was very important continuing work with the task force to have a place that we could have our eyes, on. We had any issues, we had the ER across the street, across the road from the MCATs. But as we've grown into this and our procedures have gotten much more fixed, we're able to kind of create a recipe, a cookbook of what it can take to put the vaccination in different areas. So we call those pods. So we have been offering pods in different locations. We've gone to different parts of the island. We've also partnered with the churches to offer vaccinations after church service. Also, the other changes we've made are to help streamline the registration process. Again, learning from what we implemented in the beginning, we had a very strict registration process into our electronic health record that was at the beginning of the registration process. We've learned now how to take that process and have it at the back end, so it allows individuals to come to a pod, simply register onto our vaccine system, get their vaccination, and we work with others to complete the EHR process afterwards, so it doesn't hold them up. So we recognize people are going back to work, they have lives. We want to create that. We want to do due diligence with the data we need to collect. It is an invasive procedure. We need to make sure we document correctly, but we also want to be able to get folks in and out so that they can get it done. So we're at that point now with folks who are they're willing, but they need a little bit of push. As far as what are the other ways to get folks in, if you have any great ideas, please share with them. I don't know about a lottery in CNMI, but if you're funding it, I'll buy. Yeah. Yes, well, we're still waiting for our $1 million. So.
Okay, thank you. I know.
Thank you. Thank you, Rep. Sablon. Any other members? For the fourth round? All right, at this time, we want to thank you, CEO Munya, to the rest of your team, and on behalf of the committee, please extend our appreciation and gratitude to all the healthcare professionals, and we appreciate all the work that you've been doing, and if there's anything that the committee can do to assist CHCC with its request to the governor for additional funding, we'd be more than willing to help you with that. And in addition to that, if we can get a copy of your request as well, so that we can also include it in a resolution that the committee plans to, to adopt in support of the additional requests from agencies and how these funds will be spent. I know there's a forum tomorrow. I'm not sure if I believe the head of autonomous agencies and government agencies were invited as well. And so we hope to hear good news from that. We are expecting a budget revision by July 1st. And so we'll see if any of your additional requests were included. But with your list, that'll help the committee in pushing forward with that request. And so with that, I do see other members from your organization, so I will reserve the public comment period if anyone would like to make any statement. And so before we move on to public comment, I would like to hand over the floor to you, CEO Munya, if you have any closing remarks you'd like to give.
No, thank you again for the opportunity. Thank you again for the opportunity and for allowing us to share with you our challenges and what we hope to accomplish with additional funding. You asked us, Representative Vaughn asked about the CMS findings. I want to go back to my initial statement in the beginning where, our staff are there throughout the operations of COVID, testing, vaccination, and surveillance. And, we've been talking about this for many months since we started this, that we also had a hospital to run. And, we were concerned about the visit from CMS. And mind you, we've never had a big team that big. I mean, we had 10 people that were here to look at CHCC, and we were actually in the process of handing over some of our responsibilities with vaccination to a contracted service. And they're the ones that are actually in the pods and in doing the vaccinations now. So, while that has occurred, please think about the staff that are really working hard to try to make things happen. And, we really owe a lot to them. And they're here to support us because they've been asking for a lot of things. And a lot of times they come to my office or to Pearlie's office, and we have to think about, what can we do? What can we provide? I would like to give them that pat in the back with some benefits that they've been asking for. So these are the people that are going to be there. They've been there. They're going to be there, and we hope that we can continue to work together and make things better for this community, because we are all committed. We want to do it, and we just want to, like I said, let's do it together. Thank you.
Thank you, CEO Munya. At this time, members, we will now move into the next item on the agenda, public comment. Would anyone from the gallery like to give brief remarks? If there's none, we now move on to announcement. Any member have any announcement? We do have our next budget hearing for DPS on Tuesday and defense on Thursday, and we may be scheduling a committee meeting on Wednesday to discuss the excise tax bill. So just to keep you guys updated on that. All right, members, if there are none, we now move on to the next item on the agenda. Can I get a motion to adjourn? Motion was made and seconded. All in favor say aye. Aye. All opposed say nay. This meeting is adjourned at 2:40 p.m.
Thank you so much.